want to thank everybody for joining us this evening and joining our first install for webinars into the gastroenterology market. And tonight's webinar entitled Management of Difficult Bile Duct Stones with the Holmium YAG Laser Through the SpyGlass. And tonight's presenter, Dr. Sandeep Patel, who is the assistant professor down at the University of Texas Health Science Center in San Antonio. Dr. Patel, I'll turn over the talk to you right now.
Great. Thanks, Mike. Thanks for the introduction. Welcome, everybody. First of all, I'd like to thank and introduce my collaborators. I think we've got almost everybody online. We've got Dr. Paul Tarnasky from Dallas. Hello, Paul.
Hello.
We've got Dr. Michel Kahaleh from Virginia. Welcome, my friend, long time. And I think we have Isaac Raijman, who will hopefully be joining us near the latter part of the talk. So what we have in store for you is about a 15, 20-minute presentation. And what we hope to do is introduce you to SpyGlass and laser lithotripsy, then share our clinical experience and how it's affected our practices. Follow that up with some discussion on safety parameters, and end it with some technical tidbits that might help you get started. So with really no further ado, let's get started here, and let me know if things are showing up on your screen. Are we okay? Slide number 2?
Yes, we are.
Great. All right. Well, we all know that bile duct stones are a big problem, no pun intended. We have approximately 200,000 patients a year that present to us for ERCP stone extraction. Generally speaking, we're pretty good at taking out all of these stones. You know, with our current modalities, which include sphincterotomy, extraction balloon basket, and the addition of a mechanical lithotripter, we're successful 90% of the time. So the real question is, why not 100%? And I think we can all respect this slide. Some of our limitations include altered anatomy or altered patients in which we can't perform a big sphincteroplasty, balloon sphincteroplasty, or can't perform sphincterotomy to the maximal anatomical extent, as you see over here with a saddle tick. In cases where you have large stones, greater than 2 to 3 centimeters, in patients with intrahepatic stones, in which access is an issue, and stones above of a stricture of any size, those can create some serious limitations in which our success rates go down. In those situations, historically, we've either had to refer patients to a regional center with expertise in cholecystoscopy that perform electrohydraulic lithotripsy or laser lithotripsy. In situations where those are not accessible, we have to go on to surgery or refer our patients for surgery. Now, you know, what SpyGlass has done, and, you know, I'm going to pause this up here for a second. We'll get into that. Single operator cholangioscopy, or SpyGlass, from Boston Scientific is making electrohydraulic lithotripsy and laser more accessible and available. And here is the setup. For those of you who have little experience with this or are not that familiar, it includes a disposable catheter spyscope with working channels that's put down through the working channel of the duodenoscope, the optics, guide wire, biopsies, forceps, and laser probes go through the spyscope. As he's showing you here, the spyscope has full directionality and steerable capabilities, and here's an example of what you see. You know, the visualization is pretty good, fair, for what fiber optics allows us. It helps us in terms of diagnosis. It allows us for directional biopsies, and for what we want to talk about tonight, it allows us to pass a probe, whether it's you know, laser lithotripsy, and allows us to apply the laser under direct visualization. So you can see somebody with PSC and marked inflammatory changes. Here you've got somebody with a stone. Here you've got somebody with a stone in the setting above a stricture. which we didn't know at the time, and we were able to do directed biopsies. The directionality, the steering capabilities of SPY allows us to guide wires into ducts that were not accessible via traditional fluoroscopy. Here's an example of directed biopsies. So I think you guys get the point. We'll go on. The underlying principle of laser lithotripsy is the fact that we use light to create a high-energy shock wave that's then capable of fragmenting stones. Various lasers have various absorptions and wavelengths, and one of the benefits of Holmium is that its wavelength allows for a much shorter tissue absorption, and it's approximately about 1/10 of Nd:YAG, and we'll go into what that means if some questions arise at the end. But the laser, what it does is it creates a sonic bubble, which acts as a kind of a traction beam, keeps the stone generally at the tip of your probe. The wavelength or the lack of tissue absorption allows you to cut through the stone and not worry about a lot of scatter, and hence minimize your tissue absorption and problems that incur with that. So let me share some of our our initial experience. What we did was we looked at our first 31 patients that presented to us, referred for laser lithotripsy in the setting of refractory stones. You see the demographics there, 31 patients. Most of them are female. Average age of about 59 years of age, our oldest patient being 95. That wasn't mine, by the way. Can't remember who did the 95-year-old. But I want you to come down here. We have where the stones were. We'll go straight to stone size. Average stone size was almost 2 centimeters, largest being 3 centimeters. Patients presented with, on average, 2 failed ERCPs, as many as 6. The number of sessions that were required for clearance for our group was 1.2, with a majority, or at least 3/4 of them, requiring only 1 session. I think that's a pretty big comment right there. Ductal clearance was achieved in all patients, 31 out of 31. Procedural time ranged from 5 minutes to a little over an hour and a half. Which has gotten a lot better with our experience. And most importantly, procedural-related complications were none. That's our first 31 patients. We're going to present that at DDW here in a couple of weeks. So as if we may, we never like to say 100% in anything in medicine, but it sure would be nice to be able to claim a 100% success rate for stone extraction with the addition of laser. Got a few examples of what this looks like. Our first video. Here we have the stone in view. You'll see that the laser probe come out at approximately 8 o'clock. And this is where the new version of SpyScope, the SpyScope 1.5 or SpyGlass 1.5 has really helped us. The steerability of that laser probe is so much easier than the first generation, and allows you to really place the probe right on the stone. And here you can see for short bursts of about 5 seconds, we'll put, and you get almost a cholesterol sample of a patient here. Next slide. It was an 82-year-old lady with a high-grade stricture distal bile duct and an average size stone, about a centimeter, a little over a centimeter. The problem was this was a hard pigmented stone that we just weren't able to crush. We weren't able to capture. We weren't able to pull with a basket or a balloon through the stricture despite dilating the stricture. So here we were able to get to the stone, place our probe on the stone, fragment it here fairly easily. And I like this example because what it does show you is it shows you that the visualization is good. The stone is staying right on the tip of the laser probe, and you can almost just chisel